Thank you very much. Good afternoon, everyone. Good afternoon. Can you please give your neighbor a hug and tell him or her, welcome to the session? A hug. Just a simple hug. Thank you very much. So on behalf of the government of Tanzania, I'm privileged to moderate this session. And I really wanted to acknowledge the presence of the high-level government officials who are here from the Ministry of Health Mainland and also from Ministry of Health Zanzibar. Dr. Fatma, can you please come closer to Dr. Rashid? Only for this session, yeah. You're seated very far ahead. Alice, please, can you come in front? Or you want to stay where there's an AC, yeah? That's fine, it's okay. So with that note, we are going to have a very exciting session with experts from the Ministry of Health, from mainland and Zanzibar, and we really wish to share experience on how we have been able to roll out HPV vaccination program in Tanzania with specific focus on the switch from 2-dose into single dose, and we are going to learn a lot today. And before we start, I really wanted to acknowledge the presence of our director from TAMISEMI mainland, who is not anyone else except Dr. Rashid Mfaume, who is currently our Director of Health Services, Nutrition, as well as Social Welfare Services from the mainland Tanzania. But we also have the presence of the Deputy Director of Preventive Services from Zanzibar, Dr. Fatma Kabole. Thank you very much for having you both. I know it's afternoon and people are tired, but we really wish to have you a few quick opening remarks before we start. And finally, I really wanted to acknowledge the presence of our country director from Jhpiego, Tanzania, and who is also my supervisor. Back, you can see her at the back. She's a Mzungu, but married to a Tanzanian who is from Dodoma, Mgogo. Wifi oye. Wifi oye. Asante sana. Naomba nitumie nafasi kumkaribisha Dr. Rashid Mfaume. Karibu sana for a few remarks. People are tired. Just few keynote address. Karibu.
Jambo, good afternoon. So as Melos introduced me, I'm Dr. Rashid Mfaume, who is the Director of Health, Social Welfare and Nutritional Services at the PRAJ. On behalf of the government, specifically the President's Office, Regional Administration of Government, I'm standing here just to provide and to submit our commitment as a PRAJ, who has a role of translating the policies, policy guidelines, implementation, putting implementation into practice at the subnational levels up to the community level. So coming to a title of this forum this afternoon, we are there ready to collaborate with all stakeholders, including the private sectors, in ensuring that the state administrative and performance coverage of HPV vaccination among adolescent girls is reached, age 19 to 14 years of age. And to us as a PRAJ, this we are sure by switching from 2 doses into single dose, with that evidence, scientific evidence, even the coverage will be reached, but with our collaboration, joint collaboration. Thank you, Jhpiego. Thank you, Mary Laws, Aris Christian, Country Director. Thank you, Minister of Health. And as we all know, as a PRAJ, we are aware that if you rank according to X facility data, the prevalence of cancers among women, I think cervical cancer ranks number 1. So it's actually aligns with the problem, aligns with the strategic plans. And I remember the words of the Minister of Health, the former Minister of Health, Umi Mwalimu, who was emphasizing on adolescent, not all adolescent, even women, especially for those who are aged up to 30 years of age. When you are celebrating your birthday, please remember to do a screening, integrated screening for cervical cancer, breast cancer. But if you are from 40 years and above, the age itself is the risk. Do it twice. Kina mama oye. And even we men, 1%, we are at risk. My brother, we are at risk of breast cancer for 1% prevalence. So we are there also, at least. So we have to join efforts as well. So thank you very much for inviting me to stand and just to say a few words. And you have emphasized it and overemphasized that. Please, just few words. Thank you very much, audience.
Thank you very much, Dr. Rashid. Jamani, makofi ya watoshi. Tupige makofi. Najua tuna njaa, tumechoka. Thank you very much. So with that note, I really wanted to call upon our panelists. And we have approximately 6. We'll try our level best to shorten our presentation and talk. But the aim of this forum is for you to learn at the government level, in collaboration with different partners, how we have been able to reach 98% coverage in 8 days. Not 1 year, not 1 month, not 2 weeks, but rather 8 days, okay? So our first panelist will summarize their CV. They have got a very long CV. It's going to be Dr. Amin Abdul. We call him Abdul, but he's an expert in immunization. You can come forward and sit where your name is. Let's give him a round of applause as he comes. He is really an expert in immunization at the global, regional, and country level. Karibu sana, Abdul. And then our second panelist is Mujuni. Mujuni, where are you? Oh, he's actually a very strong member of immunization at the national level with rich experience in immunization, as well as data management, monitoring, evaluation, and everything to do with that. Mujuni, karibu sana. You can sit where your name is. And our third panelist is the only female panelist, and she's called Priscilla. Priscilla, where are you? Why are you seated at the back, Jamani? And her husband is here in this forum, so be careful, the men who are here. And she's a very strong immunization guru in service delivery. And she has really run a very big show when we started implementing April this year, 2024. And then our fourth panelist, another Zanzibar team. We have our guru in demand creation advocacy, communication, social mobilization. And his name is Magarawa. Magarawa Karibu. He's very strong in immunization component in the context of demand creation. He's married and he has 2 wives. And then our fifth panelist is a very young man and very handsome. He has worn a very nice suit, but he's single, not married, but he's not anyone else except David, but very much experienced in ICT. So he has worked very well with other partners to develop the system which he really wants to share with you today. David, karibu. I'm emphasizing you're single, you never know. And then our last panelist is, when HPV vaccination is concerned, the Ministry of Health worked very, very close with the Ministry of Education. So we have a representative from Zanzibar. Okay, one of Minister of Education coordinator at the district level from here, Zanzibar, Unguja. Karibu sana mwalimu. Let's give him a round of applause as he comes. So partnership in progress. So with that note, IT, can you please put the slide? So while he's putting the slide, I really wish to recognize the presence of Jhpiego team who are here. Jhpiego team, just raise your hands from different programs. Thank you so much for coming. The first PowerPoint. So not that one, go back. Go back to the first slide. Not go back, yeah. So before we start, I thought of giving you just the basics on cervical cancer, specifically HPV vaccination, because we know not everyone is good when immunization is concerned. Next slide. So we are all aware that HPV as a virus is sexually transmitted, okay? And very unfortunately, we have so many subtypes, more than 100 subtypes. But we are so much worried with high-risk subtypes, which are approximately 20. And majority of them cause different type of cancers. So we normally talk about cervical cancer alone, but this virus causes how many? You see how many organs are there? You can see cervical, vagina, vulva, and you can also see penile, oral, and anal. So how many cancers? Yeah, can you count? Yeah, 6. HPV is in between. So that being the case, when we vaccinate our girls, we are not protecting them against cervical cancer alone, but rather 6 different cancers. And all these cancers are very much prevalent in Tanzania. So currently what we are observing in different cancer institutes, Ocean Road Cancer Institute, Bugando, as well as KCMC, we are seeing an increase or rise of oropharyngeal cancers, okay? Oropharyngeal cancers, which normally we can get by, especially for people who really love to do oral sex. Okay, so I wanted to create that alarm on the purpose so that we can continue protecting our children and making sure they understand the impact of HPV as a virus, not only to cervical cancer, but all the other cancers which are associated. But on the other end, the key message, another very important key message, condom does not provide 100% protection. Very unfortunate, this virus lives in different epithelium, okay? So the epithelium is not covered by condom unless we have condom like Jhpiego. Okay, so even if you use condom, you will only be protected by 60%. So that's another key message I wanted you to be aware of. Cervical cancer is killing a lot of women in Tanzania and globally too, and 50% of them, they end up dying in Tanzania. So it's alarming. But on the other hand, at the global level, we are actually guided by 3 main guidance. We have 90, 70, and 90 targets. 90, we really want to make sure 90% of the adolescent girls are vaccinated by the time they reach 15 years of age. And we have to make sure 70% of the women are screened. And those who are screened and found to have probably early cervical cancer changes or invasive cervical cancer, they are actually treated, 90% of them. And our target group for HPV vaccination is 9 to 14 years adolescent girls, and boys as well. But unfortunately, because of the cost implication in Tanzania, we can't afford to vaccinate boys for now. So that's another key message I wanted you to be aware of. And then we have 2 options to give adolescent girls and boys 2 vaccines or a single vaccine. But we switched to single vaccine in April based on the global evidence as well as WHO evidence. So with that note, next slide. So this is just a photo, not to scare you, but to be aware the value of HPV vaccination. So the left one is the cervix, which is very smooth and nice. But the right one is the cervix, which already has cervical cancer. You can see an ulcerative lesion, and we can protect our women from this, especially future women, through HPV vaccination. Next slide. So the outline of what we are going to do in the next 1 hour, we'll try our level best. I'm done with the opening. I'm done with basic one-on-one, and we are going to watch a video, which is going to take approximately 5 minutes, a testimony from our key stakeholders and beneficiaries from Zanzibar. Let's see what they have to say. We really wanted adolescent girls to be here. We have one of them here, Harriet Weshi. And let's hear what they have to say about HPV vaccination, as well as one of our community leaders who is called Share from Zanzibar. So Adam, please go ahead. The voice.
Wa kidato cha kwanza, nina miaka 14 na Masud Omar, ni mwanafunzi wa skuli ya sekondari Regeza Mwendo, ni mwanafunzi wa kidato cha kwanza, nina miaka 14. My name is
I have 12 years old. I live at Mombasa. My school name is...
Masud Omar, ni mwanafunzi wa skuli ya sekondari Regeza Mwendo, ni mwanafunzi wa kidato cha kwanza, nina miaka 14.
My name is Rose Kaleza. I have 12 years old. I live at Mombasa. My school name is Francis Maria Albama School.
Kwa majina naitwa Hassan Rajab Bakari, ni sheha wa shehia ya Mwanyanya, lakini pia ni mwenyekiti wa masheha wilaya ya Magharibi A.
Saratani ya shingo ya kizazi ni saratani ambayo hutokana na mabadiliko ya chembechembe au seli zilizoko katika shingo ya kizazi.
Cervical cancer is a disease that caused by human papilloma virus. I myself, I have been vaccinated on early 23 April 2024.
Mimi nimechanja dozi moja na imejitosheleza kujikinga na saratani ya shingo ya kizazi.
Nashukuru sana kupata hichi kitu ambacho kimekuja kwenye wilaya zetu na mashehia yetu ya chanjo ya saratani ya mlango wa kizazi. Kiukweli imetupa faraja sana kwa shughuli zetu ambazo tumezifanya tukazifanikisha kwa kuwapatia chanjo watoto wetu walioko mashuleni na wengine kidogo wakiwa wako nje ya shule ambao hawajasoma, lakini tulishirikiana kupitia wasaidizi wetu wa afya na viongozi wasaidizi wa masheha, yani wajumbe wa masheha, kuweza kuwatafuta kila walipo kwa kufanikisha shughuli hizo, na tukafanikisha. Chanjo hiyo ilienda vizuri sana, lakini pia tulishukuru sana kwa sababu ili swala kabla ya kuja tulikuwa na mikakati tukiwa na wakuu wetu wa wilaya, katibu tawala na uongozi mzima wa wilaya kwamba hichi kitu kimeletwa kutokana na serikali zetu wanavyotupenda. Marais wetu wametuteremshia ili swala kwa kuweza kuhami nguvu kazi zetu ili twende vizuri, kuliko kutibu inaleta madhara zaidi, kwa sababu inatumia thamani kubwa kuliko kuweza kutibu tukapata mapema tiba hiyo, basi tutaenda vizuri.
Na washauri wanawake wenzangu ambao wanasoma na waliokuwa hawasomi, mkisikia taarifa kama hii ya chanjo ya saratani ya shingo ya kizazi, ni fursa kuitumia hii bahati, kwa sababu huwezi ukajua kama una saratani. Kwa hiyo ni bora uje kabisa kupata chanjo.
My opinion is this service to be included to all girls from 9 to 14 years in the country.
Hili swala limeletwa kutokana na serikali zetu kutupenda. Kwa hiyo inapotokea zoezi hili, basi tujitoe, tutakapowapitishia kwamba tunahitajika kufanya hili, wawe tayari kufanya chanjo hiyo, kwa sababu wametuletea kwa mapenzi na kuondoa gharama kubwa ambayo tunaweza tukaja tukaitumia baadaye, ili kwamba tuweze kutumia sasa hivi kwa kuweka chanjo ili asitokee maradhi haya. Kwa hiyo tunaotoa wito, inapokuja tu tukiwatolea taarifa kuna chanjo hii ya saratani ya mlango wa kizazi, basi tuwe mbio kuweza kuwajibika na hilo.
Thank you very much. Big applause to the Zanzibarian beneficiaries. Okay, for the interest of time, we are starting with our first panelist. Abdul, are you ready? Yamani, can we have another microphone there? THS team, sorry, we are going to use the same. Ipwe? Okay, Sante. So, Abdul, you are the program manager for so many years. We know you have so many strength immunization program, and you participated in developing, implementing, thinking, and also advising the country, both mainland and Zanzibar, on how we need to roll out HPV single dose and multi-age cohort. So I have only two simple questions. One, tell them the rationale, why did we switch? And then the second question, just give us your experience as a technical advisor, being in so many bodies. How did we collaborate and partner with other different key stakeholders to roll out in April 2024? Karibu.
Thank you very much, Madam Moderator. As all you are aware that United Republic of Tanzania, we introduced HPV vaccine in 2014 as a demonstration project in Kilimanjaro region, but we scale up countrywide in 2018 April. So since we introduced the vaccine, the HPV vaccine, United Republic of Tanzania, we used a schedule of 2 doses for HPV. And the major challenge for the country was the dropout of between HPV-1 and HPV-2. So you deliver HPV-1, but it becomes very difficult to make sure that you cover all the girls you vaccinated first dose to make sure that you you reach the same level of coverage during the second dose. So in 2022, there were a lot of papers, scientific papers conducted in several countries indicating that HPV vaccine or a single dose HPV vaccine can be enough to protect the girls with cervical cancer with the same level of protection as you receive the 2 doses. But this was complemented by the WHO Scientific Advisory Group of experts, we call it SAGE, a recommendation, which was delivered in 2022, which advised the countries that they may decide to use a single dose HPV vaccine or continue with the 2 doses schedule of the HPV vaccine. For the country, for the United Republic of Tanzania, we decided to switch from 2 doses to a single dose. It was not easy because it was needed a process to make sure that we are going to switch from single dose to 2 doses. First step was to table this issue to Immunization Technical Working Group of the country. So we sent to the Immunization Technical Working Group of the country. It was discussed, critical reviewed, and then agreed that the country may switch from single dose to 2 dose. But the second step was to make sure that we give the feedback to the government concerning on this decision. The government accepted our 3 ministries, Ministry of Health Zanzibar, Ministry of Health Mainland, and PRAJ. Then we sent this a recommendation to the THS. We call it THS Tanzania, which is National Immunization Technical Advisory Group, for recommendation also and advising the government whether to switch from single dose to 2 doses. So this, the THS also agreed with our proposal and then give us the recommendation to the government. So the government accepted this and then sent back also to ICC, which is a governing board for the country to advising on immunization issues. And then finally, all recommendation from the THS, from National Immunization Technical Working Group and ICC was sent back to the government. And April this year, country decided to switch from 2 doses schedule to single doses schedule. And nowadays, we are using HPV single dose as based on all recommendations and scientific evidence provided by several countries and recommendation from SAGE. So there was a lot of collaboration in all process between the government and the partners, because in all these bodies, partners also are involved. From Technical Working Group, we are partners. ICC also, we have partners, but also the THS Tanzania comprises the secretariat from the partners and IVD. So the whole process was in collaborative between the government and partners. Thank you.
So thank you very much, Abdul. Our expert is the program manager in Zanzibar. 2 key points. 1, we have evidence. 2, we decided to switch based on the evidence. 3, different key stakeholders were involved. So let's move to Priscilla. Priscilla Kinyunyi, he's married, he has 3 children. I'm repeating. And Priscilla is leading the service delivery unit in the Ministry of Health, IVD Mainland, and she led everything when service delivery is concerned in collaboration with other partners. So we really want to learn in terms of partnership and also just tell them step by step, how do we do rollout when service delivery component is concerned? Karibu.
Thank you, Mary Rose and Jhpiego, for giving us this opportunity to sit in this platform to share the experience for the introduction of HPV single dose, as elaborated by the program manager from Zanzibar, after recommendation from the NITAG, which is a national advisory, technical advisory group for immunizations. Then the recommendation was endorsed by the ministry, by the government. So that was the first step. And after approval by the government, the second step was to submit to Gavi. And after Gavi approval, we had now to write the third stage, the HPV single dose introduction action plan, so that we could secure fund for introductions. So after we wrote it collaboratively with partners and government, engaging also Zanzibar Ministry of Health. And after securing the funding, mobilization of the resources, where we were able to secure 2.6 million USD that were for the operational fund, for training and social mobilization and supervisions. And also we were able to secure vaccine from Gavi for almost like 5.6 doses. Then the second step, after commitment from the Gavi, we had now to write the implementation plan and the roadmap for the introduction of single-dose HPV. Another step after implementation plan, we have to develop now the guideline, where the technical guideline to guide us during introduction and SOPs for the healthcare workers, and also to develop the training packages. We had the previous guideline that we used during introduction in 2018, so it was not much work. We had to update and review the existing information and new update for information. After that, we went for the cascade trainings, and after cascade training, where from the national TOT to regional up to the health facility level. Then we had to do to review the monitoring plan, where the system for data management, which my colleague will share, and other IC material for advocacy and community engagement. After training, the advocacy and community engagement was done. Then there were pre-implementation supervisions that were done by both the regional and national levels, where including the partners. Then we introduced, and introduction was for 4 days. Then we went for mop-up, which goes to 8 days. And we did an evaluation after implementation of the campaign, of the intensification activities. And the key reason that we came to REN, there were 3. It was government ownership and leadership at all levels that guided the achievement that we have seen. And another key lesson learned that we gathered during implementation of SWITCH, it was good and efficient coordination among Ministry of Health, PRAG, and Ministry of Education. Engaging the teachers and education sectors was a game changer for the 8 days to achieve that big result. After engaging the regional educational officer from the whole country, where they were trained and oriented, they were able, when they returned back to the regional, to mobilize teachers and to engage them so that they could do micro-planning and registration of girls before the day 4 intensification, when we started the campaign, or intensification as we call it. Another key success, it was efficient engagement of all stakeholders. Partners like WHO, Jhpiego, UNICEF, CDC, USAID, Gavi, the community themselves as community health workers, and all structures of the government that ensured the government to achieve those results that we can see for the 8 days. So Mary Rose, I have a lot to talk. I think I have said it all.
Thank you very much. They were giving me some urgent instructions. So thank you very much, Priscilla. Key take-home message are 3. 1, engagement of different key stakeholders. Implementation plan was developed. Different resources were developed. Great collaboration between mainland and Zanzibar and also partners. But in addition to that, engagement of Ministry of Education was a great changer. So with that note, let's move to another speaker. And our next speaker, let's switch to Kiswahili briefly, because I heard based on the current conversation, the guest of honor will be here at around 2. So we really have to be brief so that we can also go for lunch and also attend the closing ceremony. So I'm so sorry, our speakers. Other official engagement has interfered our session. So Mwalimu Ahmad, pole. Mwalimu Hamad Salim, Saif Salum, yeye ni District Educational Officer kutoka Magharibi A Zanzibar, na alishiriki kwa karibu sana kwenye zoezi letu. Mwalimu, naomba tu bullet 3, wewe ni mwalimu, najua unaweza kusummarize. Wewe kama kiongozi ukisimamia walimu katika shule unazosimamia kwenye wilaya yako, hebu tuambie mchango wako ulikuwa ni nini na wale walimu walifanya nini kuhakikisha watoto wetu wachanje. Karibu sana.
Asante Dr. Kwa upande wetu sisi kama viongozi katika maeneo yale, kubwa tulisimamia mpango kazi. Mpango kazi ndio uliotoa direction nani afanye hichi na nani afanye hichi. Na baada ya kupata uelewa mpana wa hii taarifa ya hii kuhusiana habari ya shingo ya kizazi kutoka kwa wadau hawa wa sekta ya afya, kwa upande wa sekta ya elimu walitushirikisha kutoka ngazi ya Wizara ya Elimu, tukashuka chini hapo tukaandaa mpango kazi. Mpango kazi ambao ulimgusa kila mhusika. Upande sisi wa maafisa mkoa, maafisa wilaya, walimu wakuu na walimu wote washiriki katika hii program. Na baada ya mpango kazi huo ndio sasa uliomudu kutimiza hili takwa la siku 9 kuweza kumudu hii hali ya kufanikiwa kwa hili zoezi. Na nakumbuka kwa ujumla walikuwepo upande wa masheha walishiriki, upande wa mapadri walikuwepo walishiriki vizuri. Pia na kwa upande sisi kama ni walimu, basi tuliweza kutoa taarifa na kupokea taarifa zilizowasilishwa kupitia kwa wadau wa afya. Hizi taarifa ndizo zilizochapuza sasa kila upande kuona kwamba yeye ni mhusika wa 100% kuweza kupambana na hii hali na kuweza kulisaidia taifa letu hili. Kwa hiyo nashukuru sana, asante sana.
Asante sana mwalimu, pole. Nimeambiwa na dakika 20 za kumaliza session. Kwa hiyo speakers wanaofuata please summarize. So thank you very much mwalimu. So we are moving to our young blood and young generation David. David is an IT expert. IT kule nyuma, naomba tuweke slides please. So he's going to take us through how we managed to develop Afya campaign digital platform, which was used countrywide in all 31 regions, making sure that we get daily data during intensification and also during other campaigns. So David, karibu, the floor is yours. Instead of 10 minutes, just summarize everything in 5 minutes. Pole. Next slide. Next. Yeah.
Thank you, Shangazi. I always call Dr. Meroz Shangazi because she's very young and beautiful. Yeah. So, as my fellow colleagues say, we managed to develop the Afya campaign system. There was a lot of challenge before. We managed data manually on a paper based. That's why we hope to come with a system. There was a lot of challenge, including quality of data. When data stored manually, you can lose those form register, so you lose the quality of data. But now we have a system. Before there was a challenge of access to those information. There was no single source of access those campaign data, but also issues of costing. We print forms, those register manually. So Afya campaign come with, as a solution to those challenges. Issues of workload. Also, it was a big challenge for the previous campaign. Yes, next slide. Yeah. Now we have after campaign system. This come to address those challenges that was happening before. Now we have a single source of access those information, but now even the high level can make analysis plan based on information that they have through after campaign system. You can see the dashboard there. After campaign give you the visualization, the picture, where you come from, and you can plan and give the direction. Even the country can plan for the future campaign. You can see there's a number of facilities that have reported. After campaign give you the picture of number of those that have used, but also business process that was done manual can done, same applies to the system. You can plan, maybe you can have a target. So you can add the target through after campaign system, but there is a color code, green, blue, and red. Blue does indicate the target. Green show the performance, and red, in case if you didn't reach the target, red can highlight that. Next slide. Yes. So we receive so many feedback, positive feedback, but this is because of the collaboration. My dear sister Priscilla was speaking about a little bit about the collaboration. This is because we engage stakeholders from different sectors, healthcare workers, district immunization officer, regional immunization officer, even the partner. We collaborate with PATH Tanzania. Thank you so much, guys, in developing the process. So this was a lesson learned. Another issue is centralized team. By the time when we implement after campaign, we managed to centralize a technical team together. This is because we develop after campaign in a very short period of time, so we're supposed to provide a technical service to the end user. And we are trying to think out of the box. We didn't have what we call a tool or any system that manage campaign data before. But after campaign came as a solution to manage those campaign data, the previous one. Next slide.
What's that?
Yes.
Summarize.
Okay. The future direction of after campaign. Now we plan to implement after campaign to Zanzibar, not because we're in Zanzibar, but that was one of our plan. But another policy, government policy or ministry, is to integrate those systems. So how can we integrate these guys and work together is through integration. So we plan to integrate after campaign with DHS2 and other systems that operate under Ministry of Health. Yes, next slide. Yes, on the left side, this is a technical team during the HPV campaign. And on the right is one of our training. We conduct some of the training through Dooms. Yes.
So thank you very much, David. Give round of applause to all of the former speakers. While you are going up, please tell them, does this system actually use patient level, client level data or aggregated data? As a follow-up question.
Thank you.
Quickly.
So far, after campaign operate up to the facility level, and then data manager add those or feed those information to after campaign and goes direct to the district level. Then district level provide those information as aggregate to the region level.
Thank you very much. So thank you very much, David. So we are moving to our next speaker, and is Delphinius Mjuni. Delphinius is an expert in M&E. Time is not on our side. Please give us the numbers. Karibu. Next slide, IT.
Okay, thank you, Dr. Mary Rose, and good afternoon, ladies and gentlemen. Just to take you through the performances after HPV mark switch. To start with a scope and target, The plan, and actually that's what we implemented, was to vaccinate in all vaccinating health facilities, to include Tanzania mainland and Zanzibar. Therefore, we have 31 regions with a total of 195 councils. But the target population for single dose for my age cohort, remember that we had to split it into 2 cohorts, the 9 years and 10 to 14 years. For 9 years, for the cohort from 10 to 14 years, we are targeting 4.1 million girls. But for 9 years age, our target was around 900,000. And we also, based on the requirement for HPV's max switch, we also had a plan for 3 doses schedule, especially for girls who are immunocompromised. But during the mark intensification exercise, these were also part of either the 10 to 14 or 9 years based on age of the girl. If I can take to the next slide. So initially the plan was to conduct the HPV mark switch exercise in 5 days, but it will end up implementing in 8 days. And
so Uni, sorry, somebody's behind me here. Just summarize. 3 minutes. 3 minutes summarize.
So a total of 1 million of girls, 9 years, but overall we managed to vaccinate 4.8 million girls out of 4.9. You will see a slight change in the target because Kilimanjaro region has already vaccinated the age group of 10 to 14 during before we did the mark switch, because they were used as how we call it. It was like a demonstration project in Kilimanjaro, so they were able to vaccinate 10 to 14 girls. So if you can take next slide. So as far as vaccine utilization, total of you can see we are able to manage also to take into consideration vaccinations of girls, but also managing the usage of vaccination. Our utilization was at 99.7 with an average of wastage rate of 0.23. But you can see we are managing and also monitoring the wastage rate also vaccination utilization on daily basis. And the graph down below that shows the trend of vaccinations for the whole 5-6 days during the campaign. Next slide, please. So overall, we did vaccinations in both in the community and school. As you can see, most of our girls we reached were in school, whereby 87% of the girls were from schools and only 13% that were vaccinated in the community. You can see regional performances from the highest coverage, which were in Tanga, to the lowest, which were in Irukwa for Tanzania mainland. Please, next slide, please. But also, as far as district is concerned, it was difficult to put district by name, but rather we thought of using a map. You can see most of the regions, most of the councils that you have, you see with the blue, it means they had a coverage beyond the expected target. So they went beyond 100%. But for the green ones, these were within the expected target of 90 to 100%, but still you have yellow ones that were in a coverage between 80 to 89, and the one that are in red had a coverage below 80%. And you can see the list of the councils that had coverage below the targeted during the campaign. Next slide, please. Okay, now this one is just to show the vaccine that we are done by strategies in schools, but also the age groups between 10 to 15. So the one that you see on your left, this one shows the percentage of girls vaccinated by age group, whereby you can see most of the ones, of course, you can see that one has a bigger cohort of 10 to 14. But also we are monitoring the 9 years, and you can see Kilimanjaro region, as I was mentioned earlier, they were the leading one, especially in vaccinating girls of 9 years, because most of the 10 to 14 were already covered during their routine program. But for the vaccinations in schools and in the community, the one that you see on your right, you can see Zanzibar had almost 100% of girls that were vaccinated in schools, comparing to other regions, and you can see Rukwa, which had 72% vaccinated in schools, but still they had about 29% that were vaccinated in the community. So this one was to monitor the strategies that were used in schools, but also in the community. Next, please.
Thank you very much.
That is the last slide. You can see we have a mix of boys and girls in the pictures. That's one of the strategies that we use. We use boys also to pass messages to their home, to their households, but also to the family and the community to make sure that we get much attention, but also a message passed across. Thank you.
Thank you very much, Mjuni. You give it to Bakaka. Sorry for pushing you. I'm also wind up. So Bakari, very good. Thank you very much, Mjuni. That was excellent for giving us the numbers. They have seen, they've recognized. Haikuwa kazi ya kitoto. Kwa hiyo Bakari, naomba few reflections. We know you are a guru when community engagement is concerned. You've been there in the community for so many years. But Zanzibar experienced some challenges during HPV single dose rollout. Okay, we experienced some resistance from community leaders, religious leaders. Can you tell us what happened and how did you mitigate that challenge? Karib.
Thank you very much. As you know, Zanzibar, HPV is a new intervention. So you're supposed to engage community to ensure that this is a special issue for our kids, especially 9 to 14 years. So we try to engage community by implement our activity for using a lot of intervention like media and to invite some special leaders like community leaders, sheikhs, religious leaders like sheikh and other padri from different aspects to ensure that all important people they have enough knowledge and to ensure that they inject their mindset. This HPV vaccination would have no problem because the people that have rumors this HPV vaccination, they are going to destroy the hormone of their kid and they give them some give us some people to give the fear. So according to our plan, they provide a lot of implementation of the request for provide health education by using television, sports, media sports, and to ensure that community they have enough knowledge and to implement without a problem. But still, they try to use like ESC material to display in the schools and to sit together with a school committee and other teachers, especially the health teachers, to ensure that this knowledge is injected to the students, especially 19 to 14 years, without a barrier of the vaccination our kids. Thank you very much.
Thank you very much Magarawa. Kwa hiyo kwa Kiswahili hebu tuambie ile changamoto ile ya mlioipata mlifanyaje?
Asante. Kama mnavyojua jamani, hili ni jambo jipya kwenye jamii. Kwa hiyo kulitokezea changamoto, baadhi ya viongozi wa dini na baadhi ya walimu walikataa watoto wasichanjwe kwa kuhofia kwamba tunakwenda change hormone na vitu vingine. Nafikiri yote mnaelewa hilo kwamba jambo jipya linakuwa na changamoto. Kwa hiyo tulichokifanya ni kujaribu kukaa nao kwa pamoja na kuwaelewesha kwamba hili ni jambo ambalo dunia yote sasa hivi inafanya hii vaccination kwa sababu tunakwenda kupunguza haya maradhi ambayo yanakumba watoto. Kwa hiyo tulichokifanya ni kukaa pamoja na hao viongozi wa dini pamoja na kamati za shule kuhakikisha kwamba jambo hili wanakuwa na uelewa nalo, na nashukuru baada ya kuzuia watoto wasichanjwe, baada ya muda mfupi tu walituelewa na tukaweza kuingia kwenye shule na kwenye jamii na tukafikia hiyo 100%. Nawashukuru.
Thank you very much. So let's give big round of applause to all the speakers. So we apologize on behalf of Tanzania Health Summit. It's not me. We are supposed to get out and go and eat so that we can follow the protocol. And we are not going to have a Q&A session. We also prepared something else which was a surprise, including some presents. So tunaomba udhuru sana. So without not, speakers, Mungu awabariki sana. Thank you so much for sharing your expertise, your commitment to prepare everything you have done. So let's give them a big round of applause as they come down. Mtasubiri msiondoke ili kusudi tupige picha mwisho. So the last session is going to be closing. Alice, can you please come with us? So we are going to have a closing just event of very few minutes, and Dr. Fatma Karibu, come hapa basi. So we have an award from THS. Today it's an award day for all the partners. So give it to our Deputy Director of Preventive Service, and they'll give it to Alice. So big round of applause. Thank you very much. Asante sana THS for recognizing Jhpiego contribution in this meeting. And with that note, thank you very much for having me. And I'm married, I have 2 boys. So I'm handing over to my supervisor, lovely supervisor, to give us some closing remarks. Thank you, Alice.
Great, thank you so much. I'll be very short. But really, this is incredible. Like, it really is incredible to achieve this. And I think back about where we were with cervical cancer. And so we really are creating a generation that will not have this, plus the other cancers that Mary Rose said. So it's really just phenomenal. You guys should all be massively commended. What a public health triumph. I'll be really quickly in closing, but some of the takeaways that at least I took was that you used evidence-based decision-making. You used the evidence, and then you looked at what was needed for the best public health practice, and you used that to do the 1 dose. So thank you for that. That there was very strong communication and collaboration among partners. Sometimes we do not see that. In COVID, we had some pluses and minuses around COVID vaccine rollout. So I think you guys showed us it can be done, and it should be done this way. And when you do it this way, you achieve way more. 1 + 1 did not equal 2. 1 + 1 made what, 80, what was the percentage? 1 + 1, 8, yeah, a lot higher percent. A multi-sectoral approach, the use of teachers and looking at Ministry of Education and involvement was really key in your successes. I really liked that there was a cross-fertilization of mainland Tanzania and Zanzibar. I think there's best practices from Zanzibar and best practices from mainland, and as a partner, we have the ability to see both, but sometimes I think that cross-fertilization doesn't happen necessarily with the ministries and things, so it was really nice to see that today. And then really great examples of innovations around the electronic data collection system and the use of that, and how we really can look at what are the bottlenecks, like the example of the paper-based, and really coming up with an innovation to address those bottlenecks to be able to accelerate results. So again, I'd like another final round of applause for our amazing speakers and the amazing work that they've done. And here's to the next generation of girls without cervical cancer. Hurrah, hurrah, hurrah. Thanks.
Thank you very much, Ali. So while we are leaving, can the Minister of Health Zanzibar stand up so that we can recognize you? Najua kuna Wizara ya Afya, IVD na RCH walioko hapa. Asanteni sana. Mpo kutoka Pemba na Unguja. Zanzibar oye. So we have reached the end of our session. Thank you so much for having us, and the lunch is ready. We are pushed to eat, and then thereafter we go for the closing ceremony. Number 2, njoo huko. Hapa. Please, Alice, photo, group photo. Speakers mstoke hapo, tunapiga picha.